First of all, thank you to AIOC Organizing Committee and Dr. Amit Khosla for including me in this instruction course. Frankly speaking, all my preceding esteemed speakers have already covered my vast majority of talk. So I will just skip through very fast, and I will love to have an open discussion. So basically, it is a synergistic treatment between a uveitis specialist and a rheumatologist. So, but definitely the majority of patients are being referred by a eye specialist to a rheumatologist. This we have already done. So the most common cause we come across to a definable cause of anterior uveitis is HLA-B27 related acute anterior uveitis, which normally comprises roughly 15.2% of all uveitis cases. And as you can see that ankylosing spondylitis, which is now very commonly seen by us, you can see that 30 to 50% of patients with ankylosing spondylitis can have anterior uveitis as one of the very common extra-articular manifestation. So this is one of the very pressing questions that arises to an ophthalmologist who sees a new case of uveitis is what is the cause of disease and when to investigate. This is the whole list of disease with HLA-B27 positive or seronegative group, in which the most common one is ankylosing spondylitis, Rita syndrome, which we now call as a reactive arthritis. Then we see a lot of uveitis with inflammatory bowel disease like ulcerative colitis or Crohn's, definitely with psoriatic arthritis. The other common causes are Behcet, sarcoid, and tuberculosis. And what are the useful investigations of chronic uveitis? Commonly, we should order all chest X-ray should be done in all cases, especially for TB, sarcoid, lymphomas, lung carcinomas. Then you should do HLA-B27 if you're suspecting anterior uveitis, Mantoux test, HIV serology nowadays very common. Then Lyme serology. ANA is especially useful in patients with juvenile idiopathic arthritis. So ankylosing spondylitis, which is one of the most common association between eye specialists and us, is 30% of AS patients develop iritis, especially if male, and they may present with acute anterior uveitis, last for around 2 to 6 weeks, but they have a good prognosis. And what are the investigations you do? Apart from routine investigation, you do an X-ray of the sacroiliac joint, or nowadays commonly we are ordering MRI of the sacroiliac joint, because this is the area, this is the joint which is the most commonly affected, and the disease basically starts from here. So if you follow them, either X-ray is a late presentation. So nowadays, if cost is not an issue, you should do MRI, and then you should also do HLA-B27. I would like to bring to notice that all HLA-B27 should be done by PCR method. What commonly the labs are doing is by flow cytometry, and we have seen that it's many times it's false negative. And when we have repeated it with PCR, it comes out to be positive, and it makes quite a lot of a difference in the approach of treatment. And association of reactive arthritis, they may have 20% anterior uveitis, 60% can have conjunctivitis, or either of the episcleritis, keratitis, or posterior uveitis. This actually has been extensively covered, and toxo I won't discuss. Sarcoid, yeah, this is one of the other common association between V2, and they basically the patients have non-casitating granuloma, and more common in women. It has protein manifestation. I will not go into detail. But what are the investigations you do in sarcoidosis? Apart from all routine investigations like ESR, CRP, ACE level, and mind it, or not all high ACE level is sarcoidosis. This is a very big misconception that all high ACE level, literally what our experience says that it is all ACE level above 100 should be taken with serious note, but less than 100 you should investigate like CT chest, abdomen to see for lymph nodes. Mantoux, as Dr. Jha was discussing, definitely a negative Mantoux is a good marker in favor of sarcoidosis in comparison to tuberculosis. But even sarcoid can have 5% Mantoux positivity. Juvenile chronic arthritis, which is more commonly seen by our pediatric colleagues, it's common in female patients, and this is very important. They have a lot of ANA positivity. So all patients with chronic anterior uveitis who have JIA should have ANA done, because they can have complications like glaucoma, cataracts. Syphilis, I won't go into detail. Treatment part has already been discussed, but the main issue is to relieve the pain, photophobia, the blurring of vision, prevent loss, and prevent synecdoche formation. So what is important? Since most immunosuppressive agents are extremely potent and have significant adverse effect, so consideration of 3 patient-related factors is critical. Degree of vision loss or vision threatening complications, ability to adhere to therapy. I will agree with Dr. Shishir that you should have a common consent form, and we should adopt this in our common day-to-day practice, because nowadays we have a lot of litigations coming up. So, and then they will adhere to more therapy if they are involved into the therapy. And compliance is a big issue, because these patients are on long-term follow-up, so compliance is a big issue. So what's new and why to use immunosuppressives, how to monitor side effect, which one is better, this has already been covered. The aim is long-term resolution, maintain vision, and we should have a steroid free. And as a rheumatologist now, we are all arthritis patients of rheumatoid, we are targeting, like we are doing treat to target, and the aim is to have a complete remission, or what we call is not complete remission but a low disease activity, which is almost near like complete remission. Side effects definitely with steroids more than immunosuppressives, and this has already been covered. If more than 10 milligram for 3 months, you should use immunosuppressives. Anti-uveitis, mainly topical. I won't actually go into this area, but definitely steroids and later steroid sparing agents. This I would like to cover. What are the EULAR, which is an European body of rheumatology? What are the EULAR recommendation on systemic steroids? So all initial steroid dose and dose reduction, long-term dosing depends on underlying rheumatic disease, disease activity and patient response. And always look for hypertension, diabetes, peptic ulcers, fractures, osteoporosis. Look for cataract, infection, dyslipidemia and other NSAID abuse, because all these patients who are on steroid or chronic disease have some lot of comorbidities along with. Always monitor body weight, always check for blood pressure, sugars, and always look for prevention of bone loss. Mind it, all patients who are on steroid should be on calcium, vitamin D, and if you document osteoporosis, they should be on bisphosphonates. When to taper, this is a big question. Start with prednisolone 1 milligram per kg oral if systemic treatment required, and taper steroid to 10 milligram in 3 months. That should be the aim. This part has already been covered. The commonest drug like methotrexate, sulfasalazine, cyclosporine, azathioprine, mycophenolate, mofetil, and cyclophosphamide, which are the commonly used drugs. And I would like to bring it to a point that we follow British Society of Rheumatology guidelines for use of methotrexate, and the starting dose for rheumatologists is 10 milligram per week. And you should increase 2.5 milligram every 2 weekly till the target dose is achieved. So the maximum dose we use is 25 to 30 milligram, but we normally start with 10 milligram, and after 2 weeks we escalate up to 15 to 20 milligram. And Behcet's disease has already been covered. Azathioprine is still the drug of choice, and the other drug we use is colchicine and cyclosporine or mofetil mycophenolate. Anti-TNF is a recommendation. This I brought recently about a VKS disease who presented with uveitis. They have said that mofetil mycophenolate is much superior to other immunosuppressive agent in VKS disease. So use of mycophenolate as first line therapy combined with systemic steroid is safe and effective in the treatment of acute uveitis associated with VKS disease. So what is our experience at Sir Gangaram Hospital along with our ophthalmology colleagues? Steroid sparing drug dose is more than 10. Now we commonly use methotrexate, azathioprine and sulfasalazine. Less commonly cyclosporine, cyclophosphamide and MMF, but life-threatening eye disease we use cyclophosphamide and MMF, and resistance cases we are using infliximab and adalimumab. And all idiopathic sarcoid Behcet's, for Behcet's definitely azathioprine is drug of choice. Sarcoid, if you have arthritis along with sarcoid, methotrexate is drug of choice. And if you have ankylosing spondylitis plus minus B27 mediated, oral drugs are still not recommended except you have a peripheral arthritis, but if you have an axial disease, anti-TNF is drug of choice. So vision threatening use IV, methylprednisolone, cyclophosphamide, TNF blockers. And refractory uveitis, the newer treatment or what we call as biologics, which is the new drug of choice drugs. So TNF basically they are septs, and then we have monoclonal antibodies. In sept we have etanercept, and in monoclonal antibody chimeric one is infliximab, the humanized one is adalimumab, golimumab and certolizumab. So in India we have infliximab right now, we have etanercept, we have recently 2 months back we had a biosimilar for adalimumab, which was earlier, the original one is Humira, and we have golimumab which we have started using, and probably our pediatric colleague has used in uveitis in a pediatric patient, the golimumab. And these are the list of drugs. Basically the infliximab is used IV, adalimumab is subcut, etanercept is subcut, golimumab is subcut. And what are the adult indications of infliximab in which we can have the eye presentation is ankylosing spondylitis, psoriatic arthritis and inflammatory bowel disease. So prospective study of 25 patients with uveitis who had greater than 90% demonstrated resolution of vitritis, CMV retinitis and retinal vasculitis within 4 weeks after initiating infliximab. So definitely patients feel benefit after at least 4 to 6 weeks of infliximab. Etanercept, which is a subcutaneous drug, but nowadays the recent guidelines say that it has not much efficacy in uveitis. Golimumab, this is a new kid on the block, and in India at least, because recently licensed to in India, but the only approved license by DCGI is for rheumatoid arthritis. Still we are waiting for other approvals for Golimumab. Adalimumab is available in India now, and it is a subcutaneous given twice a month. So these were all about the biologics, but what are the important things about biologics? C for anaphylaxis, wait for always observe for serious infections, fungal infections, viral, demyelinating disease, cytopenias, heart failure, quite common with infliximab, and lupus-like syndrome. And then what is the indication of live attenuated vaccine? You have to avoid live attenuated vaccine when patient is on biologics, especially anti-TNF, and do not combine. So most common adverse reaction seen are infections, injection site reactions, headache, and rash. So which drug is superior? Still not known, not proven. Children definitely methotrexate who have arthritis. Mycophenolate. Adults we use azathioprine, methotrexate, sulfasalazine or cyclosporine, and TNF blocker definitely. But cost is a big issue in India. But since last 6 months to 1 year, we are having a lot of biosimilars, and which have revolutionized the use of anti-TNF. And probably down the line, a year or two, we'll have a lot of uses of anti-TNF by ophthalmologists as well as rheumatologists. So summary is that you should have a symptom relief and preservation of sight. Topical TNF definitely, steroid sparing agent for refractory disease, and TNF alpha agents have shown promising results. So if you have time, I can have one short case vignette. This is very interesting patient, and I would like all ophthalmologists to give their opinion. This was a 24-year-old male who presented to us with chief complaints of fever, breathlessness, hemoptysis, pedicellin for 3 days, and he had a discoloration of toes. And he has a very significant history. In 2010, this patient had complaints of redness and pain in bilateral eye, and he was diagnosed as episcleritis at a big multi-center hospital. He was given steroid in the form of eye drops, and he improved and orally, and he improved. But simultaneously, he also had complaint of polyarthralgia, both small and large joint. He was evaluated for RA and rheumatic fever. His ESR, CRP were raised. RF, anti-CCP, ANA were negative, and ASO titer was not raised. So he was diagnosed as a case of seronegative rheumatoid arthritis with recurrent episcleritis, and he was rightly put on methotrexate 15 mg per week and steroids off and on. And this gentleman definitely improved, but finally he left methotrexate, as most of our patients do, without consultation. Now the second presentation in April 2011, the first was in 10, he presented to a rheumatology and was referred from an ophthalmology colleague with uveitis. He had a history of urethritis and asymmetrical inflammatory oligoarthritis. He had 3 big joint involvement. He had pain and swelling of left elbow and knee and right ankle. So he was diagnosed as a case of peripheral spondyloarthropathy, possibly reactive. His B27 was negative by PCR. MRI sacroiliac joint was advised, but he refused. And so he was shifted from methotrexate to sulfasalazine, but ultimately he didn't tolerate sulfasalazine, so was shifted back to methotrexate. And after 1 year, patient stopped taking methotrexate and was again lost to follow. Now the story starts here. In January 2014, he again presented to ophthalmologist pain and redness, bilateral eyes, and this time he was diagnosed as scleritis. Any guesses from the audience what it can be? He had a history of episcleritis, then he had uveitis, and now finally he has a scleritis. He had a history of joint pains, but he landed right now with fever and breathlessness. Definitely, yeah. So in 2014, he presented an emergency with the above complaint. So episcleritis with polyarthralgia, methotrexate and steroid. When he was on uveitis, he had peripheral arthritis. And now since he has scleritis, he was put on a high dose of steroid. But we are not sure about the fever, hemoptysis and gangrene. And this was his CT finding. You can see multiple fluffy shadows, which is very characteristic of Wegener's granulomatosis. So finally his CNCA came out to be positive, and we diagnosed him as a case of granulomatosis with polyangiitis. Actually the name of Wegener's has changed to granulomatosis with polyangiitis. So this gentleman had eye manifestation, sinuses, lungs, kidney and joint. So he was given high dose pulse methylprednisolone, antibiotics, low molecular weight heparin, and he refused for IV cyclophosphamide, was so put on oral cyclophosphamide. So point of discussion is that what is the incidence of uveitis and granulomatosis polyangiitis. I will like to take an opinion from the house. How commonly you have seen uveitis in Wegener's? Is it a common manifestation? Yeah, definitely. The scleritis is the commonest manifestation. Yeah. So GPA is a rare multisystem autoimmune disease. I won't go into detail. So we reviewed eye manifestation in GPA is around 52% patients, and they might present with inflammatory mass behind the globe like orbital pseudotumor. They might present with proptosis, diplopia, optic nerve compression, necrotizing scleritis, and peripheral ulcerative keratitis. Rarely episcleritis, keratitis, and uveitis has been reported in Wagner's. So uveitis is a rare manifestation in Wagner's and is seen in only to occur in 3% of patients, according to one of the studies. So what we concluded that all patients who present with uveitis should have an ANCA testing in their routine lab testing. Thank you so much. We have to work together for a better care of patients.
Thank you, Neeraj. Any questions?